Okay, so what we're going to cover in today's lecture, we're going to go over the classification of tissues. When we cover tissues, and also in this presentation, besides tissues, the second half is going to go over some osteology for lab, some of the major bony landmarks. So let's get a good understanding first off of the four different classifications of tissues. They are epithelium, connective, muscle, and nerve. Of these four tissues, muscle and nerve are the easiest. Epithelium and connective have many subcategories to them. So when a group of cells are combined and they come together and they have similar structure and similar function, they're going to create tissue, right? Cells come together to make tissues, tissues come together to make organs, organs come together and make systems. When you get all the systems together, we now have the organism. So we have the four primary tissue types: epithelium, connective, neural or nervous, and muscle tissue. One of the big differences between epithelium and connective tissue, if you were to look at a grid paper, you know, grid paper, how it has all the vertical lines and then it has all the horizontal lines, and they just like very, very small. I think it's graph paper, right? It has just very, very small boxes in it. If you looked under a microscope and that's what you saw, and each small square was a cell, and then all the horizontal and vertical lines would be considered extracellular matrix, also known as ECM, extracellular matrix. That's kind of like the glue that's holding the cells together. If you looked at that graph paper, there are a lot more cells than there are extracellular matrix. And that's one of the unique characteristics to epithelium tissue, is you have lots of cells closely packed together with very little extracellular matrix. Now, connective tissue, on the other hand, is the opposite of that. It's where you have some cells here and there under a microscope. Let's say we're looking under a microscope and we see an erythrocyte or a red blood cell, and then we see white blood cell. They're not so closely packed together. They could be separate, very far apart from each other, with lots of extracellular matrix that we call plasma. And I'll show you what that looks like. So when you have lots of cells closely packed together with very little matrix, that's epithelium. And when you have some cells here and there, not closely packed together with lots of matrix, that's connective tissue. Under nervous tissue, we'll talk about the neuron. We'll talk about the neuron and some neuroglial cells, but primarily focusing on the neuron. And then under muscle tissue, there's only three types of muscle, and we'll talk about those three types, which are skeletal, smooth, and cardiac. Now, tissues have very distinct structures, and if they have distinct structures or patterns, they're going to have unique functions. Right? Structure determines function. And the arrangement of the tissues, when they're arranged in a particular way, we know they're going to form an organ. When we study the tissues, that's called histology. Remember, when we're studying cells, that's cytology. The study of tissues are histology. When we look at epithelium first, epithelium is going to create a lining or a covering of the body, right? It's going to line and cover things. And one of the first things that comes to my mind when I think of lining or covering, I think of the skin, right? I think of the skin. It's covering the external surface of the body, but what part of the skin? The epidermis. And if you look at the word epidermis, you have the word epi, which means above, and then dermis is the skin. So it's this layer on top, right? When I was a little kid, kids would tease each other, and they would say, your epidermis is showing, your epidermis, and we thought like, oh my God, is my fly down or something, right? It's epidermis is the skin. No one was really teasing me, but anyway, so your epidermis is showing. The skin, the outer lining, that's epithelium. Epithelium also lines the body cavities and tubules within the body. Cavities and tubules. So tubules, just think of a hose. That's a tube. So anything that has a hose shape in the body, like long tubes, like the windpipe or the esophagus or the intestines or the respiratory tract or the reproductive tract or the urinary tract, all of these tracts, when you look at them, they're nothing but tubes. Even blood vessels, they're long tubes. Arteries and veins, they're just a long tubular system interwoven within the body. So we are technically a tube within a tube, right? You have the body, which is a tube, and inside it are other tubules. So all of those tubules are lined with epithelium. Glands are also classified as epithelium. Glands like sweat gland, your oil gland, the mammary gland, the glands in the ear that produce wax, right? Glands are a type of modified epithelium. And they have different functions. They protect us. It's used for absorption and filtration and excretion and secretion. They sound alike, right? Secretion is what your glands release. It is a secretion from the gland. So the mammary gland will secrete milk. Excretion is part of like elimination, to get rid of, right? So in your kidneys, right, our kidneys will filter. They filter blood and they filter to clean and to detoxify. And what the body doesn't want anymore, it'll just excrete. Absorption is really, when I think of absorption, I'm thinking about taking in nutrients from the body. I think of a sponge that can take in and absorb water. The intestines are absorbing nutrients. The stomach is taking nutrients in as well as the small intestine. That is absorption. Protection, I know I went in opposite order, but it's fine. Protection, if we think of the skin, for example, right? The skin, we said, is the epidermis of the skin. It protects us from friction, from the invasion of certain bacteria. It protects us against chemical damage, right? It's our first line of defense. The first line of defense of your immune system happens to be your skin. Now, there's also ciliated epithelium. Now, cilia, when I think of cilia, I just think of small hairs. That's what cilia are. And these hairs can beat rhythmically. So we have cilia in your respiratory tract, especially on top where your trachea is. Women have cilia in their fallopian tubes, also known as the uterine tubes. So if there is intercourse that's taking place and there is ejaculation and sperm now enters the vaginal area and it's moving up into the vaginal canal and it moves past the uterus and it moves into the uterine tube or the fallopian tube, that's where the sperm meets the egg. Okay, and that's where fertilization would take place. But then the cilia beat rhythmically to kind of move that fertilized egg down into the uterus where it belongs so that implantation can take place. So the cilia are beating rhythmically. In the trachea, they're beating upwards. They're beating from inferior to superior, so that dust particles and foreign particles are moved away from the lungs, up and out of the body. So epithelium is really important. And there's also sensory receptors. The epithelium that covers the body surface contains many body sensory organs. I mean, how else do you know that a mosquito or an insect is crawling on you? How would you know unless you felt it? There has to be some sort of sensory receptor that picks that up. Okay? So the cilia and microvilli are within the same family. It's just cilia are much longer and slender extensions, whereas the microvilli are more microscopic, microvilli. They're smaller projections. But both of these can come off the cell membrane, right? The cilia can come off the cell membrane and it helps to move secretions. It helps to move fluids across the cell surface, and it can even move a cell. The microvilli, on the other hand, these are smaller, and these are used more for absorption, for more absorbing nutrients, and for secretion. Okay, so microvilli are located within the intestines. We'll see them there. Now, when we look at epithelium, we have to be able to identify it and give it a name. So you may hear of a name like simple squamous epithelium, or simple cuboidal epithelium, or stratified squamous epithelium. So how do we name things? How do we name epithelium? So one of the things we have to do is when we look at it, we have to go, well, does it look like it's one cell layer thick, or does it look like it's more than one cell layer thick? And if we think it's one cell layer thick, then we say it's simple. And if it's more than one layer thick, we say it's stratified. Now, the layer that we're looking at to give it the name is the top layer, or the apical layer. When you look at the word apical, it sounds like apex. The top layer. We're looking at the top layer and going, is it one layer or multiple? That's how we get the first name, simple or stratified. Then we look at the shape of the cell. Well, does it look like a cube? We call it cuboidal. Does it look like a column, like a tall building? Then we call it columnar. Does it look like a flat, irregular shaped cell? Then we call it a squamous cell. So now let's put it to the picture, right? So let's look at the image in the middle here, where it says simple cuboidal. If we look at this, we see that it's only one cell layer thick compared to down below, we see two layers. If we look up here on the top left, simple squamous, we see it's one layer. When we look down below, we see multiple layers on the top, again, towards the apex, multiple. Let's look at the cuboid cells. Notice that they look like squares or boxes, so they're cuboid. Let's look off to the right. Notice these aren't cubed, they're columns, so these are columnar cells. If we look off to the left, these are flat, very irregular shaped, so we call it squamous. In fact, when we look at the skull, if you look at the skull and you review some of the sutures of the skull, one of the sutures is called a squamous suture because it gives the appearance of a squamous cell, very irregularly shaped. So again, when it's one cell layer of irregular shaped cells, we call it simple squamous epithelium. When it's multiple layers, right, we're not talking down on the bottom, right? Because I would agree, on the bottom, they look cuboidal. But when we look at the top few layers, this is flat, and even these are flat. So even the first 3 to 4 layers are flat or regular, so it earns the name stratified squamous. This earns the name stratified cuboidal because it's more than one cell layer thick. Now, let's look at columnar for a second. Notice that on the top, where it says simple columnar, these nuclei are pretty much aligned, just like all the nuclei here and all the nucleus that you see here. They're all in the center. When you look at the simple columnar, they're in the center of each cell, and they're pretty much aligned. Simple columnar. However, if you look at the bottom, look at the nucleus. They are scattered at multiple levels. So at first glance, you can go, well, the nuclei here on top are at one level, but down here below looks like one level, 2 levels, 3 levels. You may say, well, they're stratified. It's got to be 3 layers. But when you take a close look at it, it is still simple because it's not really more than one layer. This is one, this is one, this is one, this is one, right? So it's called pseudo because pseudo means false. So it's a false stratified columnar, pseudostratified columnar. Typically, wherever we see pseudostratified columnar, there will be cilia associated with it. So we'll see these along the trachea, right, the windpipe. Transitional. Transitional. The best way I can explain transitional is think of a balloon, right? If you were to take a balloon and you were to take, let's say, a permanent marker and draw some squares or boxes or even circles when it was deflated, and then you blew the balloon up and you put the air in it, what happens to the circles or to the squares? Don't they stretch? Don't they change and modify their shape when I give you that visual? Yes. So in parts of the body where the organ can modify its shape, like the urinary bladder or even the uterus, parts of the uterus, or the ureters, where urine flows, in any part of the body that can increase or decrease its shape or size, you're going to see transitional cells because the cells transition in their shape. Just think of the urinary bladder holding urine. If you have a full bladder, the shape of it is different than when the bladder is empty, and so will the cells be different shapes. Okay, so again, we have simple epithelium. It's one cell layer. Stratified is two or more layers. And again, you have squamous, cuboidal, and columnar. The squamous cells, their function is for protection, secretion, and diffusion. So we learned the word diffusion during week 1, where things can pass through the cell membrane. They can diffuse. Certain things are smaller. We said that they can passively diffuse through the membrane, and certain things are larger and they have more molecular weight, or maybe they're going against the concentration gradient where they need ATP or energy to diffuse. So diffusion is how things move across a membrane, and if we need oxygen or carbon dioxide or nutrients to move through a membrane, we don't want it to move through a column or columnar. We need a thin, irregular shaped, one cell layer thick type of cell. Okay, so that is the squamous. Cuboidal, we're going to see these with the kidneys and the tubules in the kidneys. If you were to research and look up a part of the kidney, which is the functional unit, called the nephron is the microscopic functional unit of the kidney. And the nephron has tubules. One is called the proximal convoluted tubule, and the other is called the distal convoluted tubule. So there's a proximal convoluted tubule and a distal convoluted tubules. And those tubules under the microscope will have cuboid-shaped cells. And they're used for secretion and absorption. Columnar, as we said, they just look like tall columns. We're going to find them in the intestines, and we're going to find them in the windpipe as well. The term stratified epithelium, remember we said the name, whether it's stratified or simple, you're looking at the apical surface, the top surface, or the surface closest to the lumen. So there is pseudostratified epithelium, which are really simple columnar, as we showed you before, but because the cells and the nuclei vary in height and they're at different levels, it gives it this false appearance that it's stratified. And as I mentioned earlier, wherever there's pseudostratified, we'll often find cilia attached to it. The transitional epithelium, again, it's only found in the urinary system, the urinary bladder, the ureters, the urethra, because this organ can be distended, it can be stretched, it could be filled with urine, or it could be empty. And the shape of that urinary bladder, depending on whether it's filled or empty, the shape of the cells will be transitional. Okay? So you can have simple squamous epithelium, simple cuboidal, and simple columnar. On the stratified side, stratified squamous, stratified cuboidal, stratified columnar, and pseudo-stratified columnar. And again, with pseudo-stratified columnar, we will often see cilia associated with them. And transitional epithelium, we're thinking urinary bladder. So let's take a look. This showed up on a past exam in one of my older terms where you had to drag, what's in blue. So if all you saw was epithelium can function in diffusion, filtration, secretion, and protection, that is simple squamous. So this is found, simple squamous is found on where? Where would we find it? Let's think. Diffusion. How about maybe where blood vessels are, where we need gas exchange to take place? What about epithelium can function in absorption, secretion, and protection? Remember the simple cuboidal. Absorption, secretion, and protection, especially absorption and secretion. This is the kidneys, those tubules, the proximal and distal convoluted tubules. Stratified squamous. So up here on the top, you had simple squamous. Now we're dealing with stratified squamous. I think epidermis with this. This is for protection of the underlying layer. So the top layer of skin, which is called a stratum corneum, is actually nothing other than stratified squamous epithelium. It is about 25 to 30 layers of stratified squamous epithelium, that top layer of the epidermis, called the stratified corneum. Pseudostratified columnar. This is the type of epithelium that functions in the movement of secretions like mucus across the apical surface. So in the trachea, we have cilia that are beating rhythmically upward, and you have mucus that are produced by these goblet cells. In the columnar epithelium, you have little goblet cells that produce mucus, especially in the trachea or in the windpipe, so that if dust particles are inhaled or debris, it sticks to the throat, right? It sticks to the trachea, and the cilia are beating upward, not down to bring the debris into the lungs. It's beating upward, so you can do this, right? Right, to get it up and out, all that phlegm or mucus that trapped all that debris. This is why smoking is very dangerous, folks, because where you have pseudostratified ciliated columnar cells, the smoke paralyzes the cilia and it burns it off. So you don't have any beating cilia beating rhythmically upward to get debris out, and all the debris makes it into the deeper part of the lungs. Okay, which type of tissue accommodates distension and relaxation with changes in organ volume? Well, I'm thinking urinary bladder can become distended, it can become relaxed, it can change in the organ volume. That's the only place we're going to see transitional. Okay, so now we're out of epithelium. Let's look at connective. Remember I said epithelium? Lots and lots of cells closely packed together, which is what we saw here. Lots of cells closely packed together with little cement, right? With little extracellular matrix in all of these. That's the classical feature of epithelium. When we look at connective tissue, it's the opposite. Here we are seeing some cells, but lots of extracellular matrix. And it's the most abundant and variable type of tissue that's found in the body. It's going to connect organs to each other. It can even connect to the epithelium. Okay? Connective tissue is used for support and protection. When we think of support, well, I can think of bones. That's for support. When I think of protection, I'm thinking of the immune system. I am thinking about white blood cells or antibodies, in fact. So you're going, well, how can blood be connective tissue? Well, it is perfect definition of connective tissue, because connective tissue is some cells with lots of extracellular matrix. So if we look under a microscope, you're never going to see a neutrophil, a monocyte, a macrophage, a red blood cell all clustered together like glue. They're scattered all over the place with lots of matrix in between. Fat cells, also known as adipose or adipocytes, these are fat cells. They're used for storage of energy. Really? They store energy? Yeah. Yeah, we call it triglycerides. Triglycerides are just sugar sitting in a fat cell. And that's why we tell our patients that if you want to lower your triglycerides, get moving and grooving. That's really it. You got to get your body in motion and you have to expend energy because in order to get energy to make ATP, you need glucose, carbs, and protein. And the preferred fuel source is going to go through glucose first. And all the extra sugar is your body tries to store it because sugar in high concentrations is toxic. It's toxic to your blood vessels. It's toxic to your neurons, right? You've heard of type 2 diabetes, right? That is poor lifestyle. That's control through your diet and your lifestyle. Type 3 diabetes, some of you have never even heard that. Well, when we're done, you'll probably want to Google it and go, what is type 3 diabetes? Never even heard that. But you'll see associations with type 3 and Alzheimer's disease because they're directly linked to the metabolism of sugar in the brain. It's called Alzheimer's disease. And then it's used for movement because blood, especially red blood cells and blood moving through your arteries, it's transporting materials, not just oxygen and carbon dioxide and nitric oxide and hormones and water and vitamins and minerals. So when we look under connective tissue, I'm going to move forward and then I'll come back, but I want you to see the different categories here. Under connective tissue, there's loose connective tissue. There's dense. Okay, so let's go back. There's loose connective tissue. There's dense connective tissue. And under each of these, you see there are subcategories. Under loose, there's areolar, adipose, and reticular. Under dense connective tissue, there's dense regular, dense irregular, and elastic. Then we have fluid connective tissue. Aha! Fluid connective tissue, that's the blood that I mentioned before. Because you got red blood cells, white blood cells, and platelets. But these are cells. Then you have lymph. This is all fluid connective tissue. And we have supporting connective tissue. So let's go back. You have connective tissue proper, which is loose and dense connective tissue. Then you have fluid connective tissue where you have blood and lymph. And we have supporting connective tissue where you have cartilage. And cartilage comes in 3 different flavors: hyaline, elastic, and fibro. Now, hyaline cartilage is the most common. This is what you have between the majority of your joints that are freely movable, right? Remember, there's a synarthrosis, amphiarthrosis, and diarthrosis. Synarthrosis is an immovable bone, or immovable joint, I should say. Amphiarthrosis is slightly movable. And then you have a diarthrosis, which is freely movable, like your fingers, your wrists, your elbows, your shoulders, your hips, your knees, your ankles, your toes. Those are all freely movable. So between each of the bones, there is articular cartilage, right? Articulating cartilage, where 2 bones come together. That's your hyaline cartilage. It's the most common type. It's going to cover the ends of the bones, both the proximal and the distal ends of the bone. When you look at bones, you will learn, especially long bones, like the humerus and the femur and the radius and the ulnar and even your phalanges, which are the fingers, they are considered long bones, and long bones have unique characteristics to them. They have knobby ends, very knobby ends, both proximally and distally. They have knobby ends, and those ends are called the epiphysis. It is referred to as the proximal epiphysis and the distal epiphysis. And in between, the shaft is called the diaphysis. So where you have those long bones, where those joints come together, is hyaline cartilage, whether that's between the knee, where the femur and tibia is, or whether it's where your humerus meets your scapula, where the shoulder joint is, all hyaline cartilage. Elastic is, I think of a rubber band when I think of elastic, right? It has the ability to stretch, but it has the ability to rebound back. So elastic cartilage allows for some flexibility. Fibrocartilage, that is the strongest cartilage of the body. Where do we have fibrocartilage? In between each vertebrae. They're called discs. Intervertebral discs are fibrocartilage. Where your pubic bone comes together, it's called the pubic symphysis. Pubic symphysis, that's fibrocartilage. And we also have fibrocartilage where your knee joint is, between the fibula, the tibia, and the femur. So where you have your thigh and your knee, not the patella, but primarily between the two larger bones, which is your leg bone, the tibia, the larger of the two, and the femur. That's where you're going to have a meniscus. The meniscus is a fibrocartilage. This is commonly torn in people, especially in athletes, where an athlete is running, then they stop and twist and turn. So maybe you're playing basketball and you're dribbling the ball and then you stop. Your feet are planted, you twist and you turn, and you hear a pop. That's a medial meniscal tear usually. Or in golf, or during a baseball swing, or in tennis. Anytime you're running, your feet are planted, you stop short, and your body twists and turns, there is a chance of damaging the medial meniscus. That is fibrocartilage, okay? When we look here at this picture, we're looking at, it's asking for what is the highlighted structure. Now, on these type of questions, there's a lot of red stuff, right? Red, pink, red, red, red. The thing that's, when they say is highlighted, the thing that's the different color from the rest of it. So in here, it would be this blue stuff. So think of these as cells, and everything between is the matrix. So there's more matrix than there are cells. So this happens to be hyaline cartilage. Each of these little raindrops is hyaline cartilage. And in between it, the blue is the matrix of hyaline cartilage, just to give you an idea. Now, also, let's go back here a second, because I do want to go over some of the loose connective tissue. And under connective tissue proper, let's compare loose to dense. So loose looks loose under a microscope. It's areolar. This is going to separate your skin from the muscle, right? If you take your forearm, if you take your left hand and you pinch your forearm, you can pinch your skin, but you're not pinching the muscle underneath it. It separates. So that cushion that separates it is called areolar. That's loose connective tissue. That's the padding that separates your skin from what's deeper. And it's made up of elastic and collagen fibers. These are different protein fibers, collagen and elastic. Adipose, well, these are fat cells. Your fat cells in your body tend to increase in number until you hit puberty. And then after puberty, they just increase in size. They can hypertrophy and they can atrophy. And that's why body composition is so very important to maintain until puberty. So if you can maintain healthy body composition until puberty, you're probably going to have an easier time with weight management the rest of your life. If you were a thicker child, right, and you were thicker and had more adipose or fat cells, you've got more fat cells to manage the rest of your life. Now, what's interesting about fat cells is that they're metabolically active. It acts as like an endocrine organ, believe it or not. They release inflammatory messages, which is what makes obesity and morbid obesity very, very dangerous, because it takes any inflammatory condition, and makes it worse. Whether it's anything that ends in an itis, whether it's arthritis, whether it's tendinitis, whether it's neuritis, whether it's dermatitis. Those aren't the only inflammatory diseases. There's rheumatoid arthritis, there's MS, there's cancer, there's Parkinson's, there's Alzheimer's, there's multiple sclerosis. These are all inflammatory conditions. We see it during times of COVID. Same thing. One of the biggest risk factors is what? Diabetes. Diabetes is the combination of diabetes and obesity. It is the fat cells that are involved in creating this cytokine storm, right? You heard about these inflammatory chemical messages. Many of them come from fat cells. So you really want to be careful. And weight management, when I say weight, right, we have to look at weight. Like when someone steps on a scale, and they step on a scale, and let's say they're 5'10", 200 pounds. You may say, oh, that's a lot, that's a fat person. But if you do body composition, if you do a BIA, body impedance analysis, and it discovers that of that 200 pounds, that 180 pounds of them is lean muscle and 20 pounds is fat cells, that's a healthy individual. Now you can have 100-pound, 5'6" female, that's 100 pounds, and 90 pounds could be fat and 10 could be lean. That's not healthy, right? So I just want to put it in perspective. You have to look at weight, right? If I have 2 glasses of water, if I have 2 glasses, one is 8 ounces of water and the other is 8 ounces of Pepsi, it's still 8 ounces of liquid, but which is the healthier weight? The one that's pure water. Okay, hopefully you get my point. Now, what's interesting about fat cells is not just that they're metabolically active and they produce these chemical messengers called cytokines, but they store toxins. So adipose tries to do us a favor, and when there are poisons that enter the body, rather than just shoving it into the liver right away, it stores them in fat cells. And little by little by little, those fat cells rupture and release the toxins so that the liver and kidneys can handle it at a safe pace. So now it makes us look at obesity in a very, very different manner, that these people may be living in a toxic environment and it's storing them. It's storing debris in fat cells, or they're putting toxic food in their body that's not healthy, and it's being stored as fat cells. Okay, now I could spend a whole hour just talking about adipose and fat cells, but I just wanted you to whet your appetite in terms of the significance and importance of them, especially when it comes to inflammatory diseases. Because the majority of the diseases in the United States of America, in terms of chronic diseases, are referred to as inflammatory diseases. So anything that we can do as healthcare providers or future healthcare providers, right, my students, is how can we help them reduce and maintain healthy body composition so that the adipose sites, which are fat cells, are not producing all these inflammatory chemical messages. Okay, enough on that. Reticular is also loose. That just makes up the framework of a lot of the organs. Under dense connective tissue, these are more these type of tissues and the cells that make up these tissues, they run very closely parallel to one another. So they're densely packed collagen fibers. So muscles and tendons, when you look at muscles, when I did human dissection many, many years ago, and I still do dissection in lab of certain animals at certain colleges, I show the muscles and the tendons, and you can actually see the fibers of them running in harmony. The tendons and muscles have to run in similar direction so that when they contract, the line of drive of that muscle can pull the bone in alignment. So dense is going to be tendons and ligaments. Tendons attach muscle to bone. Tendons attach muscles to bones. Ligaments, on the other hand, are the soft tissue structure that attach one bone to another bone. Okay, so ligaments hold bone and bone in alignment. Tendons are nothing other than the extension of muscle that attaches to a bone. Dense irregular, now we take these collagen fibers that were densely packed together And these things are just this, they're organized in many different directions. The dermis is dense, irregular connective tissue. Because think about getting soft tissue manipulation or a massage, right? A massage therapist doesn't just massage your skin in one direction. They can manipulate the skin in a circular motion, up, down, left, right, without tearing the skin, right? Unless, of course, there is some genetic, connective tissue disorder, and there are connective tissue disorders like Marfan's syndrome, where people have very, very, elastic, a problem with the elastic tissues in their body, and they grow very tall. Their bones are very tall and slender. Okay, elastic connective tissue. These are associated with certain ligaments, especially the vertebral column. The vertebral column is made up of 24 freely movable vertebrae. 7 in the neck, 7 cervicals, 12 thoracic, 5 lumbar. 7 cervicals, 12 thoracic, 5 lumbar. Remember, you eat at 7 a.m., 12 noon, and 5 in the evening. 7, 12, 5. 24 freely movable vertebrae. They are designed in a way that they're stable. They're pretty stable. So we don't need lots of collagen for strength and stability like tendons and ligaments. They need more flexibility. They need ligaments that have more elastic connective tissue to allow the spine to bend and flex and extend and rotate. When we look at fluid connective tissue, this is where we have erythrocytes, which are red blood cells, leuco, which means white, leukocytes, white blood cells. The red blood cells carry the blood gases, oxygen, carbon dioxide, nitric oxide. Nitric oxide is a vasodilator. Vaso means vessel, dilate means to open up. So nitric oxide opens up your blood vessels so you can lower your blood pressure. That's the importance of NO, or nitric oxide. The oxygen that the erythrocyte is carrying is being driven into the cells, especially the mitochondria, for ATP production. And then the CO2 is the exhaust that's given off by cellular respiration, right? We take in oxygen, we give off CO2, carbon dioxide, right? Cellular respiration, that is energy production. The WBCs, these fight infection. Those are leukocytes. These fight infection. The white blood cells are broken down into granular sites and agranular sites. When you get into blood, you will learn more about granular sites and agranular sites. When you get to AMP2, be sure to watch my YouTube videos. Make sure you subscribe so you get all these updates. You have to go to YouTube and make sure you subscribe. It's Nutrition Chirodoc. Nutrition Chiro, CHIRO, Doc, DOC, and you'll watch my lectures that I do on the heart and on the blood vessels. They're all accessible, whether you have me as an instructor for AMP2 or not. Platelets are designed for clotting. Clotting. So when you cut yourself and you bleed, eventually platelets are involved in forming a clot. So you stop bleeding. But we know that we can influence platelets and we can down-regulate their function or inhibit them by using aspirin or baby aspirin. That is a blood thinner. It directly affects platelets. What are other things that can affect platelets? Fish oils. Omega-3 fish oils can thin the blood in high amounts. That's why prior to most invasive surgeries, the doctors will say, stop all of your supplements. Because there was a record of a woman who went in, but she was taking super high doses of omega-3 fish oils, not within normal range. She was taking 8,000 to 10,000 milligrams. Typically 1,000 to 2,000 is suggested. So that high amount, this poor woman, had internal bleeding. And after surgery, you need to be able to clot to heal. So they discovered it was the high dosage of omega-3s. Garlic can thin the blood. Red wine can thin the blood. Vitamin B3 or niacin can thin the blood. So there are lots of natural blood thinners. Now, you don't want to do all of them because really You can see people that have black and blues on the dorsal surface of their hand, or the forearm on the dorsal surface as well. They tend to bang them and get these bruises. Lymph is also liquid connective tissue, and it is the interstitial fluid that's found between the cells of the human body, and this enters the lymphatic system or lymphatic vessels to clean it out. It's called lymph. Okay? It is really the interstitial fluid that is being purified and cleaned and returned back to general circulation. Okay, and then we spoke about the cartilage before, hyaline, elastic, and fibrocartilage. We went through that. Let's talk a little bit about bone, which is also under connective tissue. It's dense connective tissue. But we have different types of bone cells that you will learn about. There is an osteoblast with a B, and then there's an osteoclast with a C. The osteoblast with a B for building up bone. Osteoblasts build up bone, whereas osteoclasts break down the bone. Your body is constantly building up and breaking down, building up and breaking down, building up and breaking down. Whether it is bone, whether it is skin, whether it's hair, whether it's nails, whether it is red blood cells, your body is incredibly smart and knows how to build up and break down. And it does so in different amounts of time for different types of tissue. Let's say a red blood cell lives for 100 to 120 days. Then it breaks it down and recycles the ingredients and makes new ones, right? So bone is doing the same thing. You're building up and breaking down, building up and breaking down. The bone cells and bone that you're born with are not the same bone that you die with. It's constantly turning over and changing. Osteon, the osteon, it is the type of bony structure that we find in compact bone. Not spongy bone, but compact bone. That's called an osteon. And these osteoblasts that make the bone and make matrix, let's say the cement, the calcium matrix, eventually that cement and that matrix is going to harden up. And the osteoblast is going to get stuck in this matrix because it can't move and get out of itself. The osteoblast now changes its name to an osteocyte. So the osteoblast gets stuck in its matrix, and now it's called an osteocyte, and that's going to help maintain the bone. Osteoclast will break down the bone. And I'll show you what the concentric lamellae are and circumferential lamellae in a picture. I'll also show you the canaliculi and Volkmann's canal. It's easier to show you in a picture. I'll show you the lacunae, the periosteum and endosteum. I'll show you what these are in a picture here. So on the top left, this looks like it's the femur. Here's the femoral head. This is the epiphysis, the proximal epiphysis. Down here is the distal epiphysis. And the shaft is the diaphysis. The section that's highlighted right here, this part of the bone is called compact bone. This part that looks porous is spongy. Okay, so here, this is spongy bone. It's called trabecula. It's very porous looking. But here, it's compact. So this part here is compact bone. Spongy, spongy. The outer layer of the bone, the outside of the bone, is called the periosteum. So we can see the outer layer of bone that's called the periosteum, if you look on the bottom right there. And that's where tendons attach, and that's where ligaments attach. They always attach to the periosteum, which is the outer layer of the bone. The inner layer of the bone is not the periosteum, but is called the endosteum lining. Endosteum, en for inside, peri means outer. Periosteum, endosteum. Each of these circles that we see here, this entire circle is called an osteon. This is really the functional unit of compact bone, an osteon. It basically looks like a tree was cut down and it's the remnants of the tree stump. It's got all those concentric rings. They're called concentric lamellae. This is a 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 circumferential lamellae. Going around the entire outside is the circumferential lamellae. But these going around the actual osteon are called concentric lamellae. The lamellae that are in between the osteons, like here, that's called an interstitial lamellae. And what interstitial lamellae are remnants of old osteons. Remember I said bones are made and they're broken down. Osteoblast, osteoclast, osteoblast, osteoclast. So the remnants of the old osteons that were broken down are these interstitial lamellae, which are the lamellae found between each osteon. The center bone is vascular. Look at this. It can bleed. If you break a bone, look at that. You got an artery, you got a vein, you have nerve. So it goes through the center of each osteon, and that's called the central canal or the Haversian canal. Those are the blood supply. And when you break a bone, you get a pooling of blood. It's called a hematoma. A hema, like hematology is blood, toma, like tumor. So hematoma is a tumor of blood secondary to a fracture. This is just a bone model that shows all the same structures that we mentioned before. Spongy bone is number 1. It's made up of these trabecula. Compact bone is number 2, which is here. This entire section is all compact, number 2. Periosteum is the outer layer of the bone, here. Number 6 is an osteon. That would be one of these right here. Now we can look and we can find these osteocytes. Let me find it here. Let's see if I could show it to you. Number 8, where's our number 8? So if you look around each osteon, there's going to be these little black lines. Well, these black lines are cavities. They're little chambers. They're called lacunae. But the lacunae is just a small cavity that you can see here and here and here. It's a small cavity in which the osteoblast once was. It laid down the matrix and the calcium and cement, but cement hardens, and the osteoblast got stuck in there in its lacunae, in its cavity, and now it's called an osteocyte. An osteocyte, okay? So here, if we're looking at, we could see all these rings. This is an osteon. It wants to know what's highlighted here. So it's not an osteon. Okay, that's this whole circle would be an osteon. Can't be a central canal. That's the center part. It can't be lamellae because, you know, they'd have to label this differently for concentric lamellae or interstitial lamellae. And I can't see what the bottom one was, but it is lacunae. The lacunae are the cavities in which the osteocyte will sit in, okay? Connective tissue is vascular, with the exception of cartilage, tendon, and ligaments. They have poor blood supply. Cartilage has the worst. Ligaments, probably second place. So you have first place, second place, third place, tendons, because muscles and tendons do have some blood supply. They're just not that great. Ligaments are worse, and the cartilage is the worst of all. Okay, so if you damage these things, cartilage takes the longest to heal, ligaments second place to heal, and tendons would heal up pretty quick. But connective tissue, remember, it's made up of lots of cells with matrix in between. It's just the cells are not so closely packed together. 3 types of muscle. It's really not too much to cover when we do muscle. It's just skeletal, cardiac, and smooth. Skeletal muscle is the only one that's voluntary, right? Your skeletal muscle is muscle that attaches to your skeleton. The biceps, the triceps, the abdominal muscles, your pectoralis, your latissimus dorsi, your quads, your hamstrings, all of those are voluntary. You can consciously contract your bicep. but you can't consciously make your heart beat, 90 beats per minute within a second, right? You have to run to make that happen. Smooth muscle is also involuntary. Smooth muscle is called smooth because unlike skeletal and cardiac is striated. It has these striations, whereas smooth has a much smoother appearance. They look spindle-shaped, in fact. Okay, but also involuntary. Smooth muscle is around your organs, it's around your intestine, it's around your trachea, it's around the uterus, it's around the arteries, and they can contract, they just don't contract voluntarily. So when we're looking at this muscle here, notice the way the light passes through, it looks striated. If you look at this one, the way the light passes through, it looks like there are striations. But if we look here, it's a smoother appearance. Let's go back to skeletal again. Skeletal is striated, right? Like your biceps and your triceps. It's voluntary. It's anywhere you have a muscle that attaches to your skeleton. They're long, they're cylindrical, they're multinucleated cells, and there are obvious striations. Think of Venetian blinds, right? When you open and close the blinds, you can allow light to come through. So these are the striations. Striations are also found in cardiac muscle. The big difference between this one and this one, look at skeletal, let's compare to cardiac. Notice that cardiac is highly branched. There are many branches that come off. That's one major difference, as well as these intercalated discs. What you read about when you read up on cells is cells come together to make tissues, but they come together by junctions. There are gap junctions, there are tight junctions, there are desmosomes and hemidesmosomes and adherens junctions. Intercalated discs are where gap junctions come together. Gap junctions are found where there's cardiac muscle for fast, rapid forms of communication, as well as neurons. So neurons and cardiac muscle come together, and they come together by gap junctions, which are needed for fast, rapid forms of communication, so that your atriums, your right and your left atrium, contract at the same time, and then your right and left ventricle contract at the same time. It only happens because those impulses spread so quickly from one heart cell to the next as a result of these intercalated discs where the gap junctions are. Smooth muscle looks smooth. You see they're spindle-shaped with central nuclei. There are no striations here. And these are found in the organs, most of your organs, including the uterus and the intestines, the colon, the stomach, the esophagus, the uterus. Last type is the neuron. This is under neural tissue. Now notice the neuron has three main parts. There's the cell body, that's known as the soma. There are these branches that are called dendrites, that comes from the Greek word dendra, which means tree or branches of a tree. And then we have this long structure called an axon. So we have dendrites, cell body, and an axon. And if you look at your hand, literally look at your hand, your palm would be your cell body. Your fingers would be the dendrites. All 5 fingers would be the dendrites. Your forearm, where the radius and ulnar are, would be the axon. So sensory information comes in through the fingers or the dendrites, it processes it in the cell body, and the messages go away into the axon. A for away. The messages go away from the cell body through the axon all the way to the end of the axon, where you have axon terminals. And notice the axon is covered by this fat, this cholesterol, a type of fat called myelin. Now, myelin is produced by the other type of cell that we have in the nervous system. The nervous system is made up of a neuron and neuroglial cells. The neuron is the only one that is electrically excitable. This cell is electrically excitable. The neuroglial cells are supporting cells of the neural system. One of the type of cells, called a Schwann cell, produces myelin in the peripheral neural system. Whereas another cell called an oligodendrocyte produces myelin in the central neural system. So the central neural system, the CNS, the central neural system is your brain and your spinal cord. That's in the center. The peripheral neural system is in the periphery. It's everything outside of the brain, everything outside of the spinal cord. So the Schwann cells produce myelin in the peripheral neural system to speed up the conduction of the electrical impulses, to make it to the end super fast. That's the purpose of myelin. There is a disease where the myelin sheath can break down, and it affects the electrical conduction of the firing of your neurons. That disease is called MS, multiple sclerosis. MS, multiple sclerosis. It's called demyelination. It's when the myelin breaks down. Okay. After we cover the 4 types of tissues, we could then look at the integumentary system, which is the skin. And the skin is made up of all 4 tissue types. It's got epithelium, it's got connective, it's got muscle, it's got nerve. So now we can kind of put it together and bring some practicality to everything that we learned. Let's look at the skin. Epidermis, that's the top layer. The dermis is lower. So epi is above, dermis is below. Epidermis is made up of 5 layers, and they're all called stratum layers. And there's a little mnemonic, I think it's Cher loves getting skin Botox. Cher loves getting skin Botox. And you take the first letter of that, each word in that sentence, and you can figure out the stratum layers. But the top layer, Cher, C-H-E-R, Cher loves getting skin Botox, that's the stratum corneum. That is stratified squamous epithelium up on top. Below that, you got the dermis, which is the papillary and reticular layer. And there's a lot of structures here. You got muscle. That's called the erector pili muscle right there. Erector pili, that's muscle. We have nerve-related structure. Here you got a lamellated corpuscle, also called the Pacinian corpuscle. That's for deep pressure. We have a tactile corpuscle. That's superficial, that's close to the surface. That's how you can tell if, like, you know, someone's touching you very lightly, or the wind blows, or an insect hits this shaft of the hair, and it comes down and it hits these nerve root plexus. Okay, so you got epidermis, dermis, and way at the bottom you got the hypodermis, the subcutaneous, and that's where you have a lot of blood vessels down here at the bottom. That's where they give a lot of injections. That's why they're called sub-Q, a subcutaneous injection. They try and get into the fat layer. That's where your blood vessels are. And look, you also have glands. Here's a sweat gland. It's called a sudiferous gland. Here is a sebaceous gland. That's your oil gland. Again, just another model of the skin, but you can see same structures, right? I mean, down below, all the yellow is fat. Those are your fat cells or adipocytes. There's your lamellated corpuscle, your Pacinian corpuscle for deep pressure. Here is your sweat gland and your sweat pore coming up here. Here's your sebaceous gland. I'm sorry, here is your sebaceous gland, which is your oil gland. Your oils are secreted to lubricate the hair. Then it creates a watertight and antibacterial seal around the shaft, right at the epidermis. Okay, you can see the epidermis has multiple layers here, and we'll review that shortly. So now let's see, this would be drag again. Blank is a network of specialized cells that monitors the internal and external environment and initiates commands through which the body reacts. And if you had to choose between these, the only answer that you can have in terms of monitoring internal and external environment is the neural system. It's nervous tissue. Which one can be classified using the number of cell layers and the shape? We covered that. That's epithelium. Is it simple or stratified? Is it cuboidal? Is it squamous? Is it columnar? There are 3 types of blank, known as skeletal, cardiac, smooth. That's your muscle tissue. Blank is widely distributed throughout the body to allow movements of the skeleton. Well, any type of muscle that attaches to the skeleton is skeletal muscle, right? Muscle tissue. Which is diverse, abundant, and widely distributed? Connective. It connects your entire body together, connective tissue. Which one lines the body cavities, the organs, and constitutes most of the gland tissue? That's epithelium, including the mammary gland and the sweat gland, right? That's all epithelium. And then, which is composed of the neuron and the glial cells. I referred to them earlier as neuroglial cells. Neuroglial means nerve glue. It holds the neurons together. That's neural tissue. Then we have fluid connective tissue, supporting connective tissue, and connective, and all we have to do was drag and drop. So under fluid, that's blood, whether it's red blood cells or white blood cells. Under supporting connective tissue, we covered there, we did ligaments, and we did muscles and tendons and bone. That's all supporting connective tissue. So the 3 types of cartilage are connective tissue, whether it's hyaline, elastic, or fibrocartilage. And then compact bone, or the osteon, is connective tissue. Then we had the connective tissue proper. Remember areolar, adipose, and reticular? That was loose connective tissue. And then dense regular, dense irregular, and dense elastic was the dense, not loose, but dense connective tissue. This, again, drag and drop. Is it fall under connective tissue? Does it fall under epithelium, right? It gives you the 4 basic types of connective tissue. And go with the ones you know, right? Nervous is neural tissue. Cardiac and smooth muscle is muscle tissue. Epithelium has anything with simple or stratified in it. And then there's squamous and columnar. Those are the shapes of the cells, even pseudostratified. Connective, areolar tissue that was loose. Adipose is loose. Elastic cartilage was dense. Compact bone, right? That's falls under the supporting. And then hyaline cartilage also supporting. Elastic cartilage, hyaline cartilage, fibrocartilage. So give me some examples of elastic. Well, in the throat, you have the epiglottis that's very flexible. That closes off the windpipe so food gets diverted down your esophagus. How about the pinna of the ear, or the external ear, and the eustachian tube? These are all flexible. They can be squished and rebound back to their normal shape. Hyaline cartilage is at the end of the long bones. It's in the nasal septum as well. It's in the around the larynx. That thyroid cartilage is hyaline cartilage. The rings around the windpipe, those C rings called tracheal rings, are also hyaline cartilage. The fibrocartilage, the strongest cartilage in the body, those are the intervertebral discs. The pubic symphysis that runs vertical near the pubic bone. And then the articular surface of the knee called the medial and lateral menisci. Blank is composed of a network of branching elastic fibers. That's, these are the choices. It's elastic cartilage. Composed mainly of type 1 collagen fibers. And they form a parallel bundle. That's fibrocartilage. So fibrocartilage is type 1 collagen. These type 2 are really important. These are in a lot of supplements I actually give my patients that have degenerative joint disease. We give them these nutraceuticals that have type 2 collagen fibers, and they do extremely well with it. But that's hyaline cartilage. Again, just another way of organizing. Again, there's connective tissue proper, supporting, and fluid connective tissue. And then you just drag and drop in another way. So under connective tissue proper was loose and dense connective tissue. Under loose was areolar, adipose, and reticular. Under dense was regular, irregular, and elastic. Under supporting is cartilage and bone. Under cartilage, the three flavors, hyaline, elastic, and fibrocartilage. Under bone was compact and spongy. We focused primarily on compact, that had the concentric lamellae, the lacunae, the osteocytes, etc. And then blood was the red blood cell, white blood cell, and platelet. Let's take a look at some of the bones now and some of the bony landmarks, just to go change gears a little bit. So here we're looking at the lower extremity. This is the knee joint. This is the sesamoid bone called the patella. The patella has a base and an apex. This is the right foot and the right leg, because here's the great toe. So your great toe is medial, which means this is your medial condyle and your lateral condyle of the tibia. And then this is your medial and lateral condyle of the tibia. The tibia is the larger leg bone. The fibula is the thinner one. Just remember, you tell a small fib, so the smaller bone is the fibula. At the distal end of the tibia, there's the medial malleolus, and on the outside where the pinky toe is, there's a lateral malleolus. The medial malleolus of the tibia and the lateral malleolus of the fibula help to make up the ankle joint, because they articulate with this tarsal bone of the ankle called the talus. This little blue structure here is called, well, let's see, is it the patella? No, the patella is the kneecap. Is it the medial malleolus? Well, there's the medial malleolus. Is it the head of the fibula? Here's the fibula, the head is up here. Is it the lateral malleolus? That's here. So it leaves us with the tibial tuberosity. Why is it an important landmark? It's a very important landmark because it's where the quadricep tendons attach. Those large, immense muscles that cross over the thigh and cross over the patella that allow you to kick a football or kick a soccer ball, they attach right there to the tibial tuberosity. In the foot, you have 7 tarsals, and then you have metatarsals, and then you have phalanges. Okay, here is the knee joint, and we're looking at the knee from the back. And no, I'm sorry, we're looking at it from the front, my bad. I could see it better here. They removed the patella, they removed the kneecap. Here's the front of the tibia, so the tibial tuberosity would be here. This is the head of the fibula. So this ligament is the fibular collateral ligament. This ligament is the tibial collateral ligament on this side. Patellar tendon you don't see. We don't even see the patella. So now it's probably a meniscus. Is it a medial meniscus or is it a lateral meniscus? So the fibula here is the lateral bone. So this has to be the lateral meniscus. This would be the medial meniscus. All right, now we're looking at the inside of the knee. Now the meniscus is not here, but these that crisscross, those are called the cruciate. Crucify, cruciate, crucify, it means cross. And these two ligaments crisscross, so they're called cruciate ligaments. There's an anterior cruciate, there's a little typo there. There's an anterior cruciate and there's a posterior cruciate. So these are the anterior and posterior cruciate. So we can rule those out. Is it the articular surface of the fibula? Well, what did Dr. Lindner teach you? He taught you that tell a small fib. All right, so we can rule that out. This is the tibia. This is the femur. Could it be the articular surface of the femur? Ding, 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 ding. That's the winner. That's the articular surface of the femur. Okay, now we're looking at the tibia and the fibula because it tells us that. It says anterior view and posterior view. And now it wants to know what the highlighted segment is. Well, if the top of it is the head of the fibula, what would be just below the head? It would have to be the neck of the fibula. Would have to be the neck of it. What do we have here that's labeled? We have the medial malleolus here. We have a lateral malleolus. Now, these are clinically significant. The reason why they're clinically significant, let me go back to it. The reason why they're clinically significant is look at which one descends further distally. Which one goes down further? Well, the lateral malleolus. The medial malleolus is up higher. Why is this clinically significant? Because you are going to see, if you're getting into nursing, you're going to see a lot of ankle injuries. And they are typically plantar flexion inversion type of injuries. Because the foot, if your feet are planted on the floor right now, and you wanted to take the outside part of your foot and roll, keep the outside on the floor and lift up the inside layer of the foot, that's called foot inversion. That's pretty easy to do. But if you keep your foot planted on the floor and you roll your foot in and you try to lift up the lateral part of your foot where your pinky toe is, that's much, much harder to evert the foot than it is to invert. And the reason being is that the lateral malleolus, because it descends further distally, is going to prevent eversion, but because the medial malleolus is up higher, inversion ankle injuries are so much more common. And you'll just tear and damage ligaments on the lateral side, which is why the lateral ankle gets all swollen and you get black and blue and bruising. And the most common ligament to tear down there is called the anterior talofibular ligament. Anterior, because it's in front, talofibular, because it's going from the talus, which is one tarsal bone, to the fibular. Anterior talofibular ligament, most commonly torn. Here's the anterior border crest. It's that sharp ridge. It's why it hurts so much if you get kicked in the shin. There's not much tissue there. There's your tibial tuberosity. And these two bumps right there on the top of the tibia is the intercondylar eminence. What's highlighted here? Well, is it the scapula? Well, here's the scapula. Is it the lumbar vertebrae? These are the 5 lumbar vertebrae. Is it the sacrum? Here's your sacrum. Cervical vertebrae? There's your cervical, 7 cervicals. It can only be ribs 1 through 12. Now remember, there are 12 pairs of ribs, 12 on this side, 12 on this side. Each rib articulates with its corresponding thoracic vertebrae. So how many thoracic vertebrae are there? There's 12, and there's 12 ribs. That's why we use the ribs as an indicator for scoliosis. We simply have the person bend down and bend forward, let their arms hang down, and we look at the rib cage. And if one rib cage is higher than the other, it tells us that there's a curve of the spine. Okay? There are true ribs, there are false ribs, and there are floating ribs. When you look at the ribs in your book, you'll see that true ribs have their own cartilage that attaches to the sternum. False ribs don't have their own distinct separate cartilage attaching to the sternum. They share cartilage, so it's called false vertebrae. False ribs. So there's true ribs, false ribs, and then there's 2 floating ribs down here at the bottom, rib 11 and 12. They're called floating ribs because they don't have any cartilage, but they all attach to the vertebrae. So the 12th floating rib articulates to the 12th vertebrae. The first rib, T1. The last rib, T12. Let's just look at some of the bones here. Here's your frontal bone. Here is your nasal bone. This would be your zygomatic arch or zygomatic bone. This is your maxilla, your upper jaw, your mandible, your lower jaw. Temporal bone on the side. Clavicle. Cervical vertebrae. Nasal septum, which is made up of a vomer and the perpendicular plate up here, which is part of the ethmoid bone. And then we have some concha in here. I'll show you what the concha are in a second. Okay, so let's see what's highlighted. Zygomatic bone? No, zygomatic is here. Palatine? Well, palatine sounds like the palate, hard palate, soft palate. That's got to be up here somewhere on the inside of the top jaw. Hyoid bone? Now, the hyoid bone is in the throat. It's the only bone in the body that doesn't articulate with any other bone. Lacrimal. Could it be lacrimal? No, the lacrimal is up here. It's got to be the ethmoid. So it goes lacrimal, ethmoid, sphenoid. LES, lacrimal, ethmoid, sphenoid. Let's look here. Perpendicular plate. Well, I said this is the vomer. The vomer, that's down here. The perpendicular plate is just more of a superior extension of it. Together, the vomer and the perpendicular plate make up the nasal septum. Then, what else do we have? Lacrimal bones. Well, no, Dr. Leonard told you that's up here. So now we have superior and inferior nasal concha. Well, it's going to be the lower one. Inferior, superior is way up high. You can't even see it. So this is the inferior nasal concha. What concha do is they're also known as turbinates, like a turbine. So some textbooks call it the inferior nasal concha. If you have a shell and you break it in half, you could see the conch, like the spiral appearance on the inside. Or it's also called the inferior nasal turbinate, like a turbine. So when you breathe air in from your nose, it spins the air when it enters the nose, like a turbine. And any debris sticks to the mucus inside the nose. And if it's cold outside, like I'm in the Northeast, if it's cold, like it is, like 20-something degrees here today, and you breathe air in through the nose, it warms and moistens the air for us. That's the beauty of the concha or turbinates. All right, what do we have here? Well, is it zygomatic bone? No, that's up here. Is it temporal bone? No, that's up here. Is it maxilla? No, that's the upper jaw. Is it the frontal bone? No, that's up here. So that leaves us with the mandible, the lower jaw, the mandible. The mandible has these two holes. Anytime you see a hole, it's called a foramen. That's a foramen. So any of these have the word foramen in it? Mental foramen. These are called the mental foramen. The ramus of the mandible, that's over here on the side. The condylar process, you can't even see it, but the condyle is the part of the mandible that makes up the temporomandibular joint. Okay. And the alveolar process, that's where the teeth enter the jaw, whether it's the top or the bottom. That's the alveolar process. Let's look at the hand for a second. The hand, remember the foot had tarsals, metatarsals, and phalanges? Well, the hand has carpals. There's 8 of them. Metacarpals, right? The word meta in Greek means after. So carpals, what comes after it, are metacarpals. And then we have phalanges, which are the fingers. So the carpals, we have 8, and they are in 2 rows. There is a distal row, which is here. 1, 2, 3, 4. So we have 4 bones in the distal row. And then there's 1, 2, 3, 4 in the more proximal row. And if we were to name these from proximal row, we would have scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and the hamate with the hook. So this one here, the large one in the center, is the largest. It's the capital. It's the capitate. And an easy way to remember it, there is a mnemonic, and it's silly. I didn't make it up. It's just out there in internet world if you want to choose to remember it. There are others. So it goes like this. From lateral, right, because that's the thumb, from lateral to medial, proximal row first and then distal. A little silly sentence is, some lovers try positions that they can't handle. I'll say it again. Some lovers try positions that they can't handle. And I'm sure they're talking about yoga or Tai Chi or something like that, right? So when you take the first letter of that sentence from each word, some lovers try positions, so it's scaphoid, lunate, triquetrum, pisiform, that they can't handle, trapezium, trapezoid, capitate, hamate. Okay, these are metacarpals, and you would have to refer to them by number. So the thumb is digit 1, the pinky is digit 5. So metacarpal 1, metacarpal 2, metacarpal 3, metacarpal 4, metacarpal 5. The phalanges are distal to that, and digits 2, 3, 4, and 5 have a proximal, middle, and distal phalange. Proximal, middle, distal phalange. Proximal, middle, distal, proximal, middle, distal phalange. The thumb doesn't have a middle. It only has a proximal phalange and a distal phalange. There is no middle phalange of the thumb. 7 cervical vertebrae, C1, C2, C3, C4, C5, C6, C7. Most of the cervical vertebrae have these spinous processes that look bifid, or like there's a fork in the road. They're asking us to name the highlighted one. Well, I said that that is C1. That's C2. But it doesn't give you C1 as an option. You have to know that the other name for C1 is Atlas, just like the Greek god Atlas holds up the world. The world is the brain and the skull. And then C2 is known as the axis because Atlas rotates on its axis. So when you shake your head no, left to right, and you're shaking your head no, the Atlas is rotating on C2, which is the axis. Okay. Now, this one's highlighted. So we know it's C1, here is C2. Is that an option? No, but they give you Atlas and axis, and again, you have to know axis is C1, I'm sorry, axis is C2, and Atlas is C1. The Atlas also has very wide transverse processes. They're very wide, but there is no spinous process. There's no spinous process of C1. C2, 3, 4, 5, 6, and 7 all have spinous processes. Let's look at the blue. What bones are these? Well, you have, here's the radius, here's the ulna, these are the 8 carpals, these are the metacarpals. So what are the blue? Well, it's a phalange, but which one? Is it a proximal phalange, a middle, or distal? Well, here's the metacarpals, proximal, middle, distal, proximal, middle, distal, proximal, middle, distal, proximal, distal. So it's the proximal phalanges. Now let's look at the foot. Let's apply the same knowledge to the feet. The feet have tarsals, there are 7, metatarsals, and then phalanges. So let's start with the tarsals first. Here's the superior view. It's a bird's eye view looking down on the foot. Here is the talus. This is the one that articulates with the medial and lateral malleolus. So that's your talus. It's the most superior one. The calcaneus is the heel. That's your inferior one. So you have a talus, a calcaneus. This is the navicular. Then there are 3 cuneiform. Cuneiform 1, cuneiform 2, cuneiform 3. Cuneiform 1, cuneiform 2, cuneiform 3, also known as a medial cuneiform, lateral cuneiform, and an intermediate cuneiform. And the last but not least, the lateral one here is the cuboid. So first cuneiform, second cuneiform, third cuneiform, cuboid. Navicular, talus, cuboid. Those are 7 tarsals. Distal to that is your first, second, third, fourth, and fifth metatarsal. So which one is this? Know your Roman numerals. Here's 1, there's 2, there's 3, there's 4, there's 5. So this is number metatarsal 4. And then what do you have distal to that? Same thing as you had in the hand, the proximal, middle, and distal, the proximal, middle, and distal, proximal, middle, and distal, proximal, middle, and distal, proximal and distal phalange. Here's the clavicle. It's telling us, it's giving us that away. So we know it's the clavicle, but it's asking what part of the clavicle is this? This is the part that articulates with the scapula at the acromion process. Okay, so it's the acromial end. This end is the medial end that articulates with the sternum. So there ends up being a sternal end and then a flatter, wider acromial end that meets the acromion process of the scapula. Here is the longest bone in the body, the femur. Let's look at some of the major landmarks here. This is the head of the femur. This is the neck of the femur. Here's the greater trochanter, the lesser trochanter. Now the humerus has a greater and lesser tubercle. That's of the arm. But the thigh has a greater and lesser trochanter. This is the shaft. And then we have to figure out, all right, which condyle is it? Well, this is where your orientation of anatomical position comes into play. So this says it's the anterior view, and the head of the femur goes medially. So this ends up being the right femur. So this is medial, this is lateral. So it's the lateral condyle. It doesn't matter whether you're looking at it from the front or the back, it's still the lateral condyle of the femur. Okay. In the anterior side, between the two trochanters are the intertrochanteric line. And on the back, it's the intertrochanteric crest. When people have hip replacements, they actually cut this whole thing off. So right here, they cut this off, and they end up using titanium and chromium, you know, that type of metal, and they try to mimic this articulation. Some people have what's called a hip resurfacing, where they save a lot of the bone. They cut off about this much of the head, and they resurface this, and they put a metal cap and a screw in here. So in younger people, typically under the age of 50 to 55, they're still athletic. They get what's called a hip resurfacing, which is a minimal type of hip replacement where you save as much bone as possible. And there's very, very few doctors in the United States that do it and do it well. We happen to have a great one in New York City at the Hospital for Special Surgery. He teaches it across the United States. His name is Dr. Sue. I happen to know him well. I have some of his staff that are patients of mine, and I know it so well because I had a hip resurfacing done a few years ago. Okay, let's look at the skull on the inside of the skull. This is now taking the cranium, like the top of the skull, off, and we're looking in where the brain would be. This large hole is the magnum foramen. So your brain stem goes right through here, especially the medulla oblongata. These three holes right here, they're not named here, but they are foramen, and I call them ROS, R-O-S, 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 foramen rotundum, foramen ovale, foramen spinosum, ROS, foramen rotundum, foramen ovale, foramen spinosum. Same thing on this side, foramen rotundum, foramen ovale, foramen spinosum, foramen lacerum. This is the sella turcica. This is where your pituitary gland sits, also known as the hypophyseal fossa. This is the posterior clinoid process. This right here is the anterior, this whole thing, anterior cranial fossa, middle cranial fossa, posterior cranial fossa. Right here is where the holes are, is called the cribiform plate, okay, the cribriform plate, but this extension that's protruding upward is called a crista galli. The crista galli is this extension that comes up from the nose. Remember you had the nasal septum? Well, when the nasal septum pierces through the skull, it becomes the crista galli. So think of the vomer, the perpendicular plate, and that extends up here. This is the ethmoid bone, and the cribriform plate is part of the ethmoid, but these holes is where your olfactory nerve penetrates through. The olfactory nerve is for the sense of smell. If you've ever had a frappuccino from Starbucks or something, or like a ices, or you drink a cold drink too fast and you get frozen brain syndrome between the eyes, well, guess what you're feeling? You're feeling the stimulation of the olfactory nerve right through the center. And this is where it is. Okay. Okay. Here is the anterior clinoid process, and then here's the posterior. So you have an anterior clinoid and a posterior clinoid, and they're designed to kind of protect that pituitary gland that sits right here. When you look underneath the skull, here's the hard palate. There's your incisive foramen. You have a few more holes that you can see underneath. Here's the opening for the carotid canal, right? So you can imagine the carotid arteries are going to go through here. The mandibular fossa, this is where your condyle of your mandible articulates to make up the TMJ, the temporomandibular joint. Hypoglossal canal, there's a little hole right here called the hypoglossal canal for the hypoglossal nerve, which is cranial nerve number 12. The occipital condyles, these occipital condyles are important. They're going to articulate with C1 or the atlas. And it's a saddle joint. So when you just nod your head like a little yes, not a full yes where your cervical spine kicks in, but you nod, a little nod like, yes, let's get out of here, that type of thing. That's the junction between the occipital condyles and the atlas vertebrae. The mastoid process, this is the bones that you feel behind your earlobe that's on your, between the occiput and your temporal bone. It's the mastoid process. And the thinner one, this thinner line is called the styloid process. So there's a mastoid process and a styloid process. The mastoid is very important. It's where the sternocleidomastoid muscle attaches, also known as the SCM. There's your magnum foramen, that large hole. Some of your other chewing muscles attach here and here to the pterygoid process. This is the medial pterygoid process, and here's your lateral pterygoid process. And there are muscles of mastication called the medial pterygoid muscle and lateral pterygoid muscle that deviate your jaw side to side when you chew, that attach there. Looking at a different section, right? So here, if we take the skull, we cut it in half and we're looking inside of it, this is what it would look like from the side. So here's your nasal bone. This is part of your frontal bone. This is your parietal bone. This is still part of the parietal bone. Here's your ethmoid. This is all sphenoid. So that sella turcica, where the pituitary gland sits, is in the sphenoid. And you'll see that there's a lesser wing and greater wing of the sphenoid bone. The temple region, that's your temporal region. And then here's your occiput. Here's your palatine, like the hard palate. The upper jaw is the maxilla, and the lower jaw is the mandible. Cervical spine, cervical vertebrae, thoracic vertebrae, lumbar vertebrae. So the answer here is cervical vertebrae. Looking at the scapula from the anterior surface, here's the ventral. Here's the ventral. We're looking at both anterior view. Well, let's look at some of the landmarks. Superior angle, inferior angle. Borders, medial border, lateral border. How do we know it's the lateral border? Well, the lateral border is on the outside, and this is where your shoulder joint is. This is where the head of the humerus articulates. That's called the glenoid fossa or glenoid cavity. So there's a superior border, medial border, lateral border. The medial border is closer to the spine. Sometimes they call it the vertebral border. And the lateral border is closer to the armpit, so sometimes they call it the axillary border. Superior angle, inferior angle, and right there, lateral angle. There's two processes up here. This one that projects anteriorly to you, since it's an anterior view, it's called the coracoid process. And the highest point of the shoulder is the acromion process. The acromion process is where your clavicle articulated with, right? It had the acromial process, or the acromial end of the clavicle that articulates with the acromion process. Here is the acromion process. Here is the coracoid process. Here is the glenoid fossa or glenoid cavity. Here is the infraglenoid tubercle. On the top would be the supraglenoid tubercle. There's the suprasternal notch. It's just a little depression. There's a nerve that's going to pass through there. And here's the subscapular fossa. Subscapular fossa is where one of your largest rotator cuff muscles will attach. It's called the subscapularis. The subscapularis originates on the subscapular fossa. Now we're looking at the spine, and it wants to know what these highlighted structures are. Well, is it the vertebral body? No. The vertebral body are these. That's the vertebral body. Is the invertebral discs? No. The discs are these, going across, horizontal. Are they facets? Can't really tell. They're not facets. These are, and it's not the spinous process, because the spinuses are right there in the center, or from the lateral view, they're poking out this way, right? That's a lateral view. From the side view, it's got to be your TPs, the transverse processes, right? When you look at the spine from the back, or you look at it from the front, it's straight. When you look at it from the side view, you have these curves. You have a cervical lordosis, thoracic kyphosis, a lumbar lordosis, and a sacral kyphosis. It's always arcs, and that's because energy travels in waves. And whenever you lose these arcs in this plane, your body will try and restore it in this plane, and we just call it a scoliosis in that direction. We don't want that. Okay, so now we know this is the upper jaw, and this is the lower jaw, because that's the hard palate. You don't have a hard palate on the bottom jaw. Bottom jaw is the mandible. Top jaw is the maxilla. So which teeth are these? Are they mandibular teeth? No. Incisive foramen? Well, that's this. Hard palate? That's this. Intermaxillary suture? Well, that's this. It's got to be the maxillary teeth. These are the maxillary teeth. These are the mandibular teeth. Parts of the vertebrae, you got to make sure you know the different parts of your vertebrae. This one's quite unique. This is the axis, and it tells you axis, C2. It's an atypical vertebrae because it's the only one that has this structure called the dens, or the odontoid process. It's the atlas that sits around that and allows you to rotate your head to say no. So this is the superior articulating facet. Here is the transverse process, here and here. This is the transverse foramen. That's the hole where the vertebral arteries go through. So now, and right here are called pedicles. Here and here are pedicles. Here and here are called lamina. Lamina come together, they fuse to form the spinous process. So if you ever heard of a surgical procedure called a laminectomy, that's where they cut the spinous and the lamina off, especially when people have bad disc herniations. Here's a superior view, here's a lateral view, and they're asking similar structures: lamina, spinous, pedicle, vertebral body. Well, this is the vertebral body, so we rule that out. Lamina, we said, is near the spinous. So here and here are the lamina. They fuse to form the spinous. So it's not lamina, it's not spinous. Superior articulating facet. That's the superior articulating facet. That's the superior articulating facet. That's the superior articulating facet. So what's right off the vertebral bodies? It's got to be the pedicles. The pedicles are right off the vertebral bodies. Okay, well, I think I gave this one away now. Let's look. Spinous process is here. Dens or odontoid process is here. Transverse process, that's here and here. So now it's either lamina or body of the axis. Well, the lamina, that's near the spinous, here and here. So this is the body of the axis, and that's the dens or odontoid process. We're looking at a lateral view. This happens to be a thoracic vertebrae. The reason why I know it's a thoracic vertebrae is thoracic vertebrae look like a nose, like your nose angles down in this direction. Here's the vertebral body. Here's the transverse process. Here's your spinous process. Now, look at costal facet inferior, costal facet superior, transverse costal facet. Guess what these facets or smooth surfaces are for? Costal. It's for the ribs. The ribs make an attachment everywhere you see a costal facet. So there's a superior costal, an inferior costal, and a transverse costal. The ribs attach. So as your spine rotates, so do the ribs. We're almost done. Hang in there. Again, here's the vertebral body. Well, what is this? Is it a lamina? No. Spinous process? No, that's over here. Is it a vertebral foramen? No. This is a vertebral foramen right here. That's where your spinal cord travels. Your discs sit here on the vertebral body. So this is the body. If a disc herniates, it can push into the vertebral foramen. Here's your intervertebral foramen. So your nerve roots come out this way and this way. So these are your TPs, your transverse processes. Let's look at this one. Vertebral body. Let's see, is it a spinous? We can rule that out. Is it a superior articulating process? We can rule that out. Is it a pedicle? We can rule it out. Now, we're choosing between a superior costal facet or a transverse costal facet. Spinous process, transverse process, transverse process, transverse process. So it's got to be the transverse costal facet. That's the superior costal facet, inferior costal facet for the ribs. Looking at the pelvis, here's your iliac crest. And in the front of the iliac crest, as you move forward, it takes you to an anterior superior iliac spine. When you go below it, it's the anterior inferior iliac spine. This is a fossa called the iliac fossa. Here's your sacroiliac joint. Here's the sacrum, here's the ilium. That's your sacroiliac joint. The top of the sacrum is called the ala of the sacrum. Here's your coccyx. Here's your pubic symphysis. Here's your acetabulum or acetabular fossa. That's where the head of the femur articulates with. This is the ischium. This is the ilium. This is the pubic bone. So you have an ilium, pubic, and ischium. Those are the three bones on each side that make up the pelvis. Okay. Again, here's your pelvic girdle. That's your sacroiliac joint, sacral ala, here and here. Sacrum, sacral foramina, the holes in the sacrum, they're always foramen. Here's the ilium. Here's the pubic or pubis. And here is the ischium. This hole is called the obturator foramen. It's actually the largest hole in the body. It's called the obturator foramen. There's your pubic symphysis. Iliac crest, that's where your belt line would be, the iliac crest. Anterior superior iliac spine, anterior inferior iliac spine. And on the posterior, we can't see it, but there'd be a posterior superior iliac spine and a posterior inferior iliac spine. And now we can see those exactly. So this is anterior. This is posterior. This is where your sacrum would articulate with. Here's the ilium and here's the iliac fossa. Here's the pubic bone or the pubic symphysis. Here's the iliac crest. So when we move forward, anterior superior iliac spine, drop down, anterior inferior iliac spine. Go back to the iliac crest, but move posteriorly, you get a posterior superior iliac spine, and then a posterior inferior iliac spine. Here's the ischium and the ischial tuberosity, this roughened part right here. This is called the ischial spine. Significant. Ischial spine separates the greater sciatic notch from the lesser sciatic notch. Again, ischial spine, ischial tuberosity. Ischial spine separates the greater sciatic notch from the lesser sciatic notch. And guess what goes through the greater and lesser sciatic notch? The sciatic nerve. And that's why pelvic alignment is so very important, because if the pelvic bone tilts, it can put pressure on the sciatic nerve, whether it's an anterior pelvic tilt, posterior pelvic tilt, or a lateral pelvic tilt. Just looking at an x-ray, right? Still, it's an x-ray, but it's got the bones there. So let's see if we can label some of these. This is the thigh, so that's the femur. This is the large leg bone, so that's the tibia. The thinner one is the fibula. And that bump in front of the tibia was the tibial tuberosity. The bumps on the top and the center of the tibia is the intercondylar eminence. This is the articular surface of the lateral condyle, and this is the articular surface of the medial condyle. Okay, so these are both the femur. It's just because of the angle we could see the outer part and the medial part. This little bump is called the adductor tubercle. It's for the adductor magnus muscle to attach to. And here's your kneecap called the patella. Remember, this is your thigh from the lateral view. We're looking at it sideways, not front, because here's the kneecap. This is anterior. This is posterior. That's the bend or the crease in the back of the knee. So your meniscus would be somewhere in here, and so would your cruciate ligaments. Now we're looking at the spine. This is the cervical spine from the lateral view. So this is your C1 vertebrae. This is C2. So that's the anterior arch of C1, posterior arch of C1. This is axis body. This would be the axis spinous process. So if this is the axis and this is the body, that's the dens or the odontoid process of C2. So you got C2, C3, this is the C4 cervical vertebrae, C5, C6, C7. C7 has the most prominent vertebral spinous process. And after C7 comes T1, your first thoracic vertebrae. So you have to know how to count. C1 goes across, C2, C3, C4, C5, C6, C7. Those are the vertebral bodies. And these are the spinous processes. And then you got T1, T2, and T3. Okay, I think we went through the skin already, going through the different layers of the skin. Top layer is the epidermis. Then you have the dermis, and then you got the subcutaneous. When we look at the layers of the epidermis, here's where I said to know Cher loves getting skin Botox. Sometimes the stratum germinativum is also called the stratum basal. They're very close in layer. They all have stratum in front of it. Stratum like stratosphere, it's layer. These are the layers, microscopically, of the epidermis. Stratum corneum, stratum lucidum, granulosum, spinosum, and germinativum, also known as the stratum basal layer. The stratum basal layer down here, these have stem cells. And these stem cells multiply and divide, and they push upwards, and it takes about 4 weeks for those cells to reach the top. And then they slough off. They're dead cells that just slough off. Okay? So you should know those layers because I know that they like to ask them on the lab exam. So when you look at the layers of the skin, and even if you didn't know, you start to see the stratum layers, they want to know, well, all right, what's the top layer? Well, that's going to be the stratum corneum. Okay. Stratum corneum, then you got the stratum lucidum. Down here, this yellow one, that's the lucidum. So just make sure that you spend the time and review these. Now we're at the bottom layer, the basal layer. Remember, Cher loves getting skin Botox, B, stratum basal. So this highlighted one down here is the stratum basal layer. This is going to regenerate, reproduce, and push the cells upward till eventually the stratum corneum, where you have 25 to 30 layers of stratified squamous epithelium. Up here, epidermis, down here, dermis, and below that, hypodermis. Okay. When you look at the hair, right, the hair just breaks through the shaft breaks through the skin. So here's the exposed shaft of the hair. Here's your sebaceous gland that secretes oil that moves upward. Here's the erector pili muscle. So when that contracts, it makes your hair stand on end, giving you goosebumps. Here's the hair root plexus. So when the hairs move, it's going to stimulate the hair root plexus, letting you know that maybe an insect is crawling on there. Here is the hair bulb. Here is the hair root. And then here is the hair shaft. So this right here, if it's asking, well, what is this? The only thing that thing could be is hair. That's it. What is this? This is the hair root. It's not the muscle. It's not a sebaceous gland. It's not the follicle. That would be the hair root. When we look at the nails have the free edge. It has the nail body. It has the lunula. You've got the cuticle here, known as the eponchium, and then the nail root back here. From a different view, here's the free edge of the nail. We cut it. Here's that distal phalange. So we can see here's the free edge. Here's the nail body that looks pink and should look pink unless you're anemic. Here's the lunula. Here's the cuticle. And here is the nail root. Near the nail root, right here behind it, is the matrix. The matrix is epithelium, and it has these dividing cells which produce new nail cells. So when the matrix produces new nail, it pushes this forward. Okay? Same structures, just on this type of view. So if we're looking here, well, that's going to be not the free edge, not the eponchium, that's going to be the nail body. The nails are really important because you can pick up a lot of diseases from the nail, a lot of metabolic issues. When you start to see clubbing like this, that's usually involving some bad cardiac or pulmonary issue, as if there was a pulmonary or lung cancer. This is what clubbing of the nails look like. We see it in heavy smokers. Could be seen in cardiovascular disease. I've also seen it in people with inflammatory bowel disease, very, very big. People with AIDS, people with liver disease, but they call it nail clubbing. Clubbing, this is normal. This gets a little bit thicker. That's early clubbing. Then this becomes really thick, and that starts to club downward. Opposite of spooning. Spooning is like a spoon up. Okay, spooning is coming up like this. We see that typically in fungal infections and diabetics. Here's Bowes lines. I wouldn't worry too much about Bowes lines. Peronchia here, this gets red and inflamed typically when people get their nails done at a salon. If they reuse nail files or they don't disinfect properly, you can get a pretty bad infection over here. White nails, this is typically seen with anemia. The nail body should be pink, but if there's like a B12 anemia or an iron deficiency anemia, it becomes white. When you have this black streak, this is seen with a type of skin cancer. It's called a melanoma. So this is one of the indications. It's called a subungual melanoma. It's associated with skin cancer. Now you see these vertical ridges. Looks like candle wax that's dripping. This is associated with diabetes, some thyroid disorders, endocrine disorder called Addison's disease, which is a cortisol imbalance. Sometimes it's seen with stress and even B vitamin deficiency. Okay, let's stop this recording and see if you guys have any questions.